Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 50th Virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Hand Pain, Top and Common Causes, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. We use our hands in almost every aspect of our daily lives. And as humans, they are one of our greatest assets. Persistent hand pain can severely disrupt everyday life, making simple tasks like typing, writing, or even holding objects a challenge, ultimately impacting overall productivity and quality of life. Many painful conditions can develop in our hands, from injury, disease, and gradual degeneration. Tonight, Illinois Bone and Joint Institute's William Vitello, MD, will teach us about the most common causes of hand and wrist pain. Dr. Vitello is a double board certified orthopedic sports medicine physician and orthopedic surgeon with fellowship training in hand and upper extremity. He has been in practice for 19 years and with IBJI in Chicago Lakeview West office since 2020. A Midwesterner, Dr. Vitello attended the University of Toledo in Ohio, graduating cum laude with a major in biology and a minor in psychology. He then earned his medical degree from Wright State University School of Medicine, followed by 2 years of general surgery training and a 5-year orthopedic surgery program there. He then went on to complete fellowship training at the renowned Indiana Hand Center in Indianapolis, Indiana, where he received subspecialized training in hand, microvascular, and upper extremity conditions. Throughout his career, Dr. Vitello has authored numerous journals, articles, and textbooks passages, and has presented at both the National and International Orthopedic Society meetings. Dr. Vitello has extensive experience in the conservative and operative treatment of hand and upper extremity related injuries and chronic conditions. His areas of expertise include hand and wrist tendinitis, fractures, pain, injuries, and carpal tunnel syndrome. Dr. Vitello sees a wide range of patients, from young adults to the elderly, with a wide range of problems as well, from acute injuries to chronic conditions. He believes it is important to take a stepwise approach with patient care and to engage his patients' participation by listening to their complaints, their mechanism of injury, and how long they've had their symptoms. He also believes it is important to educate his patients about their condition and then explore treatment options with them, explaining the risks, benefits, and alternatives for those options. Dr. Vitello always incorporates his patients' individual preferences, values, and physical demands, and then works with them to reach a decision regarding their treatment, finding what is going on to best suit them in a direct, open, and straightforward conversation. To Dr. Vitello, the most gratifying thing is taking a patient who has had a long-term condition, one who has been in pain and disabled, and to be able to do something for them surgically or even non-surgically to get them back to where they want to be and participating in their activities. During Dr. Vitello's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Vitello immediately following his presentation. I do ask that you please keep your questions general, as Dr. Vitello will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Vitello via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Vitello, please mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, April 30th at 7 p.m. Dr. Andrew Bank will discuss healthy bones, understanding osteoporosis. Thank you again for joining us tonight, and thank you, Dr. William Vitello, for your time and effort in putting together this program to teach us about the top and most common causes of hand pain. Dr. Vitello, please take it from here.
Well, thank you everybody for tuning in. I appreciate it for you taking the time out of your evening, and hopefully everybody can gain some little bit of knowledge of what we're going to talk about here tonight. So these are the top conditions that I see. These are the top conditions that exist out in the general public, and this is what we're going to focus the talk on. The title is 7 problems. We actually have 8 here, but These are the things that I think are most pertinent, that I think will probably affect at least one person on the call or on the webinar. You'll find this hopefully useful. So we're going to start with just carpal tunnel syndrome. This is a very common condition that affects a large part of the general population. And so each slide's going to have a little QR code here in the corner. And that QR code is something I encourage you to take advantage of, and it's going to take you to this website. And this website is very informative. It has about 130 different diagnoses by the American Society for Surgery of the Hand, called the Hand Care Patient Information website. So even if you just capture one of these, the website will open up to a whole host of different kind of diagnoses that you can investigate on your own after the talk. So carpal tunnel syndrome affects 2 to 3% of the general population. And what carpal tunnel actually is when the nerve in the wrist is compressed. And so that's the median nerve, and that increased pressure in the carpal tunnel over that nerve is what causes that numbness and tingling in the hand. And so very common condition, often due to inflammation of the tendons in the wrist. And that swelling of those tendons causes a relative ischemia, which is a lack of blood flow. The nerve gets blood flow just like any other part of the body. And if the nerve doesn't have that blood flow, you can develop that numbness and tingling in the hand, as well as pain. So this is what carpal tunnel looks like. This is just a schematic, a little anatomy lesson for you. So you can see the nerve being pinched as it goes underneath that band of tissue, which is what's called the transverse carpal ligament. And when that nerve gets pinched underneath there, it's not able to conduct its electricity normally, causing symptoms. And here's just another representation of that. This is taken in cross section. So where you can see the tendons there are there in blue, and around each of those tendons is a lining, and that's what we call the tenosynovium. And if that gets swollen in that tunnel, that nerve has nowhere to go and it's trapped, and that's what causes the compression. And that compression is what then causes the symptoms. So the whole goal of treating this is to try to decrease the inflammation there and take that pressure off the nerve. Who gets carpal tunnel, or what are the risk factors? Risk factors are high BMI, which is obesity. I'm going to go back here. I'm sorry that jumped ahead. Diabetes, hypothyroidism, gout, rheumatoid. Females are more predisposed than males. Apologize, this is jumping ahead. Increased frequency during pregnancy, as well as smoking. And risk factors at work are physical, high demand, forceful, repetitive gripping, grasping, even direct pressure or a trauma to the palm can do this. Less associated things are pinching or vibration. And what's a common misnomer is this actually in the literature has never really been proven to be associated with keyboarding. I jokingly say to patients, if keyboarding was a cause of carpal tunnel, I think half the country would have carpal tunnel because everyone is on their keyboard. What happens is you get numbness and tingling in this distribution. And so it is the thumb, index, middle finger, and part of the ring finger. And that's where the pain and the numbness occur. And that is common across the board. It doesn't mean that you can't have something else associated with it, but those are the hallmark of where those symptoms occur. They generally occur at night or with activities that involve forceful repetitive gripping, driving, talking on the phone. How do we make this diagnosis? Well, we take a history. We talk about your work exposure, the onset, any outside activities or the comorbid factors that may come into play. We do a clinical exam. Sometimes it's a classic exam where we do specific tests and we can detect this pretty easily. And in that case, nerve testing or an EMG is not always needed. So we do that on occasion, but we don't do it with every single patient. So if you come in, you make the diagnosis and we don't do an EMG, it's not for lack of workup. It's just that your symptoms are so classic that it doesn't add really anything to the diagnosis. But there is a role for it. We do it at times, but just not with every single patient. So I think it's important to know I often get asked, well, how do you know that I have this diagnosis and you didn't even do any testing? Because sometimes it is just that straightforward. So how do we treat this? We treat it with usually a steroid injection. What that steroid injection does is help reduce that swelling in the carpal tunnel around the nerve. And that response to that injection is a pretty good indicator of how you may respond if and when you might need surgery. So this response and this injection is generally what we do, but not every single time, because it all depends on the length of time and the severity of the symptoms at the time of the presentation. So there are people that do come in that have had long-term symptoms for years and years. The muscles in their hands are being affected. Their fingers are numb all the time. And I tell them, you can try the injection. However, unfortunately, at this point, there may be some element of damage to the nerve, and that doing the steroid injection might not get you where you want to be in regards to improvement or recovery. But steroids are usually the first line treatment. This is done in the office. It's extremely easy to do, takes seconds, is not painful. In conjunction with this injection, we oftentimes recommend splinting. And splinting will help keep the wrist in a good position so the wrist is not bent, especially at night, because what happens is at nighttime, which is when the majority of these symptoms occur, your wrist is in an awkward position, and that puts increased pressure on the nerve, and that's when these people wake up. Most people with carpal tunnel syndrome will wake up in the night with numbness and tingling. And this is a good adjunct to the injection to help keep the wrist in a good neutral position. So both these things are often done. Again, the time frame to treatment and possible surgery, again, is dependent on how long you've had symptoms. For the most part, we do try this, but not on everybody. And we give people at least a chance to respond to the injection and the splinting before we consider doing something surgical. However, some people do need surgery. It's not uncommon, and that's usually after a failure of conservative treatment. And I stress again, time dependent on the response to that treatment. And again, the length of time that you've had symptoms, as well as the severity of your symptoms at your initial presentation. So what carpal tunnel surgery is just a release of that ligament. That just gets opened so that nerve has room so they can then conduct electricity and resolve your symptoms. And it's really not more sophisticated or involved than that. The recovery of carpal tunnel, we usually start therapy very quickly. After surgery, within about 5 days, we expect a week to return to work with light activities. 2 to 3 weeks if you have a sedentary job, should be able to go back to that. 6 weeks if you have a light to medium duty job, and maybe 8 to 10 weeks with heavy labor, but we don't anticipate any permanent impairment. And I quote the number of about 2 to 3% risk of recurrence. I often get asked if this is going to come back, and the answer is not likely. And I think 2 to 3% chance of recurrence is a pretty fair number. The other nerve compression in the upper extremity is what we call cubital tunnel. Cubital tunnel is in a completely different location. It's a different nerve. Treatment's different. Symptoms are different. And we'll get into that regarding the anatomy and the workup and the treatment as well. So it's less common than carpal tunnel. This is a compression of the ulnar nerve. I apologize, that went ahead. It's a compression of the ulnar nerve at the elbow. And the causes are sometimes postural and or pressure on the nerve, or even some trauma to that area can cause compression. The symptoms are on the opposite side of the hand. It's the small finger and the ring finger, which are the areas of numbness. Cubital tunnel is what you see here. That's the inside of the elbow. That medial epicondyle that you see is the funny bone, and that nerve travels right beneath that. And that nerve can get pinched very easily in that area due to one of a couple different reasons. This shows that again. The arrow that you see there, one's the funny bone or the medial epicondyle, and the other one is the ulnar nerves that travels through here. What's different about this as opposed to the carpal tunnel is there's generally 3 main areas: the arcadus struvers, Osborne's ligament, and the 2 heads of the FCU, are what cause that compression. And so all three of those areas, if and when surgery is warranted, have to be released. So that means we can't do an injection for this like you do for carpal tunnel syndrome, because you've got a broad range of areas that are involved that you can't lay a specific steroid injection in one spot to the same effect that you can in a carpal tunnel syndrome. This shows rather dramatically how that nerve can get kinked at the elbow when the elbow is bent. And you can see how that nerve wouldn't conduct electricity well. Elbow pads help keep pressure off the inside of the elbow. If you have a desk job or you drive a lot and you have your arm rested on the armrest. And that often helps just to remind you to keep the pressure off the inside of the elbow. Nighttime splinting helps keep the elbow straight, so your elbow is not bent at that 90-degree angle, so you don't have that kink in the nerve that can cause symptoms. We generally try this for a few months based on how your symptoms are at the time of presentation. And if we get improvement, great. Therapy doesn't always help with this. Sometimes we try therapy if you've got some associated medial epicondylitis or another issue, but therapy for this is not something that we go to first line. If we fail conservative management and we're talking about surgery, this is a little bit different because there's multiple ways to do this operation. And I spend a lot of time talking to people about the recovery, which is appropriate. It's what everybody wants to know. And the tricky thing about this is there's three ways to do this, and it's time dependent on the technique that you do at the time of surgery. And you don't always know the technique that you're going to be able to do. Surgery dictates, or the anatomy dictates, what you're going to be able to do or not do, not you dictating it. So we always try with the simplest way possible, which is what we call an in situ compression. And the recovery on that is usually about 4 to 8 weeks, and sometimes even on the 4-week side. People are back doing almost all the activities that they want to do, maybe up to 8 weeks, but very quick recovery on this, relatively speaking. As we go up in invasiveness, and sometimes it's just warranted based on the length of symptoms or the length of time of symptoms and or the patient's anatomy, it increases the time of recovery. When you do an anterior transposition, what that means is you're moving the nerve from the back side of the elbow to the front side, behind the medial epicondyle to the front side. And then sometimes in severe cases, you have to put it into a piece of muscle, and that increases the time to recovery as well. So it's often a longer conversation about recovery because you don't always know how it's going to go, but we always try to do this when we have to do it in the least invasive and quickest recovery time possible. We're going to move on to probably the most common thing I see, which is just a very common cause of hand pain, which is what we call a trigger finger. Trigger fingers happen routinely, and I don't always know why. Nobody does. I get the question all the time, how did I develop this? And I don't always have a good answer because you don't always know. The technical term for this is stenosing tenosynovitis, which is inflammation of the tenosynovium around the flexor tendon, and a thickened fibrotic pulley. And we'll show you what a thickened fibrotic pulley looks like in the tenosynovium in the finger, so you have a better concept of what that looks like. So there you see the A1 pulley. That blue is the thickened tenosynovium and the flexor tendon. And that tendon can't go through that tight space of that A1 pulley. And then just a little bit more dramatic, you see the A1 pulley here, and then you see this thickened tendon, and you can see how that tendon is not able to pass through there because the tendon is thick and the pulley's fibrotic, causing the actual triggering. Sometimes it doesn't always cause triggering. Sometimes it's just pain in the palm. And that's usually the first indication of a trigger finger. Not all pain in the palm is a trigger finger, but oftentimes, more often than not, it actually is. So treatment for this, the cause, risk factors for this are forceful gripping, grasping, prolonged pressure on the palm, or even a direct trauma to the palm can set up a cycle of inflammation, resulting in flexor tenosynovitis or trigger finger. The other thing, the medical conditions that correspond with this is what we call comorbid conditions, are diabetes, rheumatoid, and gout. And this is a very frequent condition seen in diabetics. Not everybody, but quite frequent. Depending on the severity of at the time of presentation will determine how we treat this. Grade 1 is just a painful catching and clicking. Grade 2, you can actively extend the finger. Grade 3, it's in a locked position. You need to actually pull it out. And then grade 4 is in a fixed flexion position. So determinants of treatment, we'll get into. We generally try the steroid injection. And I get asked all the time, how long is the injection going to last? And the short answer is I don't know, because it's difficult to determine the length of time or the severity of your symptoms at presentation. And injections are more effective in symptoms that have not been around as long. We're all different. Everybody on this webinar is different. People's response to treatment is different. And so it's a very fair question, but it's a very difficult one to answer. But generally, for the most part, unless you're a severe grade 3, grade 4, we try the injection as you see up here. X kind of marks the spot of where that injection goes, right along that A1 pulley. And we try that 1, if not 2 times. If you get a good response to the first injection, we'll often try a second one. And we'll do this about 4 to 6 weeks apart. Some people will get no response to 1 injection, and that's the unfortunate thing. But if that happens, we talk about next steps. But if you do get some response, it's always reasonable to try a second. We oftentimes use this kind of nighttime splint because people complain of pain or triggering, or the finger you wake up and the finger in a locked position. So this is the conservative treatment most everybody gets, at least initially, before we've decided we have to move to plan B or it's not working. So if you do have to move to plan B, very simple again, we open that A1 pulley. That area just gets open or vented and creates room for that pulley or creates room for the tendon so it can glide and you no longer have that inflammation and that pain. Recovery on this is very quick. Light activity within a week. As you see there, the sutures come out in 12 days. You want to avoid any forceful gripping for about 2 weeks, but by 90% of people by 3 weeks are back doing pretty much all the activities that they want to do. There's always outliers when risk of palm sensitivity and scar sensitivity, but for the most part, this is where I would say 90% of people lie. Quervain is another inflammatory condition. It's in a completely different spot, but I see this not quite as often as trigger finger, but equally as painful. And it's an inflammation of these tendons right along the radial side of the wrist here, as you can see. And this happens when those tendons pass through this tight area and the tendons have nowhere to go. And what happens is that these tendons get inflamed, and they're the tendons that attach to your thumb. So every time you go to move your thumb or bend your wrist in a certain position, you have pain directly over that side of the wrist. Who's at risk here? People with heavy, forceful, repetitive jobs or wrist motion. Very common in mothers and fathers with newborn children. Lifting the children repeatedly, putting that wrist in an awkward position can start inflammation on the radial side of the wrist. As well as a direct trauma. People can have just a pretty innocuous injury sometimes, or some kind of soft trauma, and start to develop pain in that area. Again, treatment dependent on the severity at the time of the presentation. We generally do try a steroid injection, just like the trigger finger, and a brace, which helps prevent the aggravation of those inflamed tendons, as well as activity modifications when applicable. This is again one where we don't necessarily recommend therapy, because that just can tend to aggravate the tendons and not give them a chance to calm down, so to speak. And so that's where the injection goes, and that's where the brace, the injection, let me just pause here, goes right along the course of those tendons. It's a steroid injection, well tolerated, easy to do. And again, I would say a vast majority of people, this is a first line treatment for them. The injection, I feel, is more effective if you can tolerate bracing with activities, and this just helps immobilize the thumb so you're not aggravating those tendons with activities of daily living, which helps considerably. So a vast majority of people get this initial treatment. And if that does fail, There's a very straightforward operation to release that tissue. That's what we call the first dorsal compartment. And this simple small incision is made over that side of the wrist, and that band of tissue, which is tight and around the tendons, just gets released that you see there. And again, it vents and opens the area for the tendons to move to stop that cycle of inflammation causing the irritation. If and when you get to that point, recovery, I tell you categorically, for the people that have this done, often wish they'd done this earlier because the recovery is generally that straightforward. The surgery is not without risk, but I'm telling you, it is very low risk. And the upside to alleviating that pain that people have been dealing with for prolonged periods of time is well worth it when and if it's indicated. So these are the general timelines. You avoid the forceful gripping, 5 pounds for about 2 weeks, and most people fall into the activities that's tolerated right around the 4-week point with therapy throughout the duration of that 4 weeks. Moving on to the next topic, which is Dupuytren's. And this is one of the outliers here because this isn't necessarily a painful condition, but affects a lot of people. And I get a lot of people in the office inquiring about their condition and their concerns. And I think warrants a few slides discussing the etiology of this as well as what to expect if and when you develop such a thing. So what is Dupuytren's or how do you get it? The exact cause is unknown. It is generally hereditary. You have no control over the formation of Dupuytren's. You can maybe think your ancestors. It's more common in men and over 40 in Northern European descent. But it's genetic, and it's something that just forms, and I'll show you how it forms and what that looks like. But this is not something that you can take a pill for or something you can do to control it. It's going to progress at its own pace. What we do is like to get a baseline and to know where it is, what the degree is, and then be able to monitor it and treat it appropriately when needed. But a large part of this is just education. Alleviating people's concerns so they know what they have and they aren't anxious over it. Related conditions are diabetes, heavy use of alcohol, and aging. It's generally not in a young person. It's usually people over the age of 50. You can be a young person, but if you're 75, 80 years old and this hasn't affected you yet, then it's probably not going to, because it is generally in a little bit of an older population. So what is Dupuytren's? It literally are lumps, bumps, nodules, bands, cords. Can be uncomfortable, but generally not. It can cause a contraction of a finger, bring the finger down into a flexed posture. That I'll show you. If people do have pain with this, I generally think they have an associated trigger finger or maybe something else going on, because this by and large is generally not a typically painful condition. I know the talk's painful conditions, but I added this just because it's so common and people have such concern over it. So this is kind of a schematic of what that looks like. You can see the nodules, the cords, and that skin pitting. And this is what people develop. These are not tendons. This is the tissue underneath the skin that is normally soft and pliable, turns into these cord-like structures and these little bumps under the skin that's pretty disconcerting for people, and they don't know what it is. And not all bumps in the hand are Dupuytren's, but quite often that is the root cause of what these lumps and bumps in the hands are. And when people present, that sometimes they can present like this. This is a little more advanced. That's a cord that we call it, and you can see how that's caused a little contracture. So that's a little bit more of an advanced case, not too advanced, but you can see here in the middle, that's what we call a nodule. And then on the right side, there's really all three here. There's a nodule, a cord, and then you can appreciate that skin pitting. Treatment on this is really based on at what point you present. And if you present with something like we see here in the middle with just that simple nodule, it's not a surgical treatment. That is something that we watch that may progress. But if you remove that, you have to remember this is genetic. Your body's going to want to form that again. So we just observe those. We don't take those out. We just observe them till they're at a point where it makes sense to remove them or treat them with another option. So what are those options? Well, this is one thing that we just gross test. We just grossly look at the hand. It's called a positive tabletop test, where the finger won't come down and lay flat due to the contracture. It's kind of one of the hallmarks that we look at, is whether that meets criteria. Mild cases, we just observe. Splinting, stretching typically does not prevent worsening, so we don't do that. One thing we do is consider sometimes doing what we call a needle fasciotomy or fasciectomy, and that's just, I'll show you a picture of what that looks like. Another thing, in advanced case or more advanced cases, sometimes surgical excision. Collagenase or Zyflex is that injection that many people have heard about that is sometimes indicated. I prefer to do the needle technique, which is very similar to the Zyflex, and there's pros and cons of doing one versus the other. And I'll kind of explain that here in a second. So this is the needle fasciotomy, where a small, just 18 gauge needle is used to just kind of pierce the skin and then go through that cord and separate the cord. And what that does is brings the finger out into a much improved position. You're not removing the cord, but you're separating that tethering effect, so the finger can get out into a better position. The cord will grow back, but usually you buy a significant amount of time by doing this and can avoid a bigger operation or a full excision if it's warranted. Some cases are more advanced or it depends on the location of the cord, where this needle fasciectomy is not appropriate. And in those cases, we do consider doing an excision. It's a more involved case, doing the excision, where we have to open the palm and then we take out that cord-like material through the whole distance where the cord is palpable. We reserve this for more advanced cases, but sometimes this is indicated to get the patient where they need to be. But again, totally dependent on the state of affairs, so to speak, and how bad the contracture is at the time of the initial evaluation. We're going to move on to another topic here, which is very common, is what we call a ganglion cyst. A ganglion cyst is often responsible for a large majority of the lumps and bumps you see around the hand and wrist. 70% of them are on the back side of the wrist, 20% are on the palm side. I'll show you where they generally occur. 10% occur along the what we call the volar retinacular sheath, and then a percent at the joint at the distal phalanx. So on top, going from top to bottom, that's a volar retinacular ganglion. The one on the second one down is on a volar wrist, about 20% of the time. Dorsal wrist, and then across the backside of what we call the DIP joint, a very common location as well. So those are the sites where this generally occur. This is a classic dorsal ganglion, and that's just a fluid-filled sac that comes out from the backside of the wrist, and it has a little stalk to it, and that stalk goes all the way down to the wrist joint. And so that's why puncturing these or smashing them with a Bible or whatever you may have thought or heard is not really effective, because you don't get rid of that stalk. And you think of that stalk as like a root to this ganglion. And if you don't remove the root, the ganglion can just reaccumulate. So we don't remove these unless they're causing pain, they're limiting your activity, or they're rapidly enlarging. If they're doing those things, we do consider surgical excision. Again, I don't recommend removing these unless they are causing one of these issues. Removing them is going in, making a small incision, taking the stalk off the base, sewing that up, and people are on their way. Leaving these there does not cause a problem. They don't turn to cancer, they don't spread, they don't press on a nerve, but they can be painful. But I do really limit removal of these for the people who are having pain. This is what it looks like off the back side of the wrist, and that's that little fluid-filled sac here. I'm just going to go back here 1 second. And we go down, we remove the stalk, and that is about 2 centimeters in size, and that's a pretty typical looking ganglion. These happen at the tips of the fingers as well. They can cause, these are what we call mucus cysts. And these cysts happen due to a bone spur that you have in the joint, usually early arthritic bone spur. And so that fluid can just evolve and come up on the backside of the finger. And you can see in the 2 pictures above, that's generally what a little mucus cyst looks like. It can cause a little groove in the nail. Again, these, we don't take every one of these out, but we only take them out if they're causing issues. Occasionally they'll drain, can get infected, or they're causing a nail deformity. And in that case, then we have a conversation about what removing those looks like. One thing, this is just 3 examples of where cysts are, how they look like at the DIP joint, and those are pretty common cysts that you see. One's causing a nail deformity, but again, sometimes they are painful or unsightly. This is what we don't do. I see this done sometimes by dermatologists. I advise against this for a couple reasons. One, you don't remove the cyst, and that stalk is still going to be there. You're not removing the bone spur. And 2, this can be a setup for infection by doing this. And so this is really ill-advised. If you are at a point where you need this removed, or it's causing pain, drainage, or a nail deformity, then what we do is we recommend surgical excision. That's what the incision looks like on that side of the finger. And we go down to the joint and we remove that bone spur. And so you can see the bone spur up top. And then after the operation, you can see that bone spur removed. And in the midst of this, we take the cyst out. And that's a very effective surgery. Aftercare is usually we start light therapy within a week. You're in a splint for 2 weeks, usually by about 4 weeks. You're doing the activities that you want to do. It's a little bit different if a finger cyst occurs at the DIP joint. Start light therapy in about a week. It's usually usually a quicker recovery. I tell all people there's still about a 5% chance risk of recurrence with this, and so it's warranted to remove if they're causing those issues, and pretty straightforward. But again, we reserve it only for the people that are having issues. Thumb arthritis, a very common condition that affects a lot of people as we all age. And I'll get into kind of what that looks like and where it is. It's the second most common of arthritis in the hand, only second to the tip of the finger. Seen in 25% of men, 40% of women after 75. More common in women for a couple of various reasons. A gradual increase after about age 60, and it's pain with pinching, grasping, and twisting. And people will come in very often with pain, and they'll point to that area directly there at the base of the thumb as what is painful. Or they'll kind of hold the base of the thumb like you see on the right. It's where their area of pain is. Here's where an x-ray is indicated. You can't make the diagnosis really without an x-ray. And this is kind of what it looks like in some terms. This is a very sore arthritic joint at the base of the thumb. That's where the arthritis occurs. Radiographically, what this looks like, there's 4 stages, A, B, C, and D, which really correlate to stage 1, 2, 3, and 4. You can see just a tiny little bit of joint space narrowing there at B, at A. B, the joint comes down just a little bit more narrowed. And then you can see here in C, the bone is actually touching in one point. And then when you get to D, which are grade 4, the cartilage is vastly worn down, and that's kind of end stage A to D, or stage 1 to stage 4 kind of arthritic changes here. So treatment for this depends on the stage of the presentation, right? So when most people come in, earlier stages respond better to steroid injections in that location. Anti-inflammatory medications are often helpful. Bracing to help support that joint, often indicated. And then occupational therapy to help strengthen the muscles around there to make that a healthier joint is often indicated. But again, stage 4, we still try these things, but the injections are not quite as effective in stage 4 as what they are earlier. If we get through these stages or this treatment, I generally recommend 3 to 6 months of non-surgical treatment. Symptoms will wax and wane. You'll have good days and bad days. But because the recovery is a little bit longer than what any of these other kind of surgeries that we talked about, I tell people to really carefully consider this. And these are kind of the criteria I tell people to consider. I don't make this determination to when you go forward with surgery, the patient does. But if you're having more bad days than good, it's interfering with your life and your daily activities, you can't do simple tasks, and I think it's worth considering doing surgery. So I'm just going to go back to this. This is really key. This is a patient-driven decision, not my decision for you. Up to the patient after we've gone through these things, and I feel the patients are properly educated, they know what they're getting into, then we can move forward, start talking about the specifics. In just real simple terms, this is what the surgery kind of looks like. We remove that arthritic bone or that arthritic surface, and then that tendon graft is actually the patient's own tendon. And this just kind of shows you a little bit different how we weave that tendon around the base of that joint and create a cushion there where we've taken the joint out. This is highly effective for the people that need it. The downside to this is the recovery, and this is a different situation than what the other recoveries are. You're splinted and you're fully immobilized for about a month, and you start therapy. Gradual range of motion and strengthening over 4 to 8 weeks. And this is really about a 3-month recovery. Patients can expect improvements up to about 9 months. Final strength and function are generally improved, and as well as a reduction in pain. But again, like anything else, it's not without risk, but when it's indicated, it's indicated. But again, due to this longer recovery, this is not something that we jump into from the onset. I just want to go back to that and just stress this point. It can be frustrating for people, but again, looking out for the patient and knowing what they're up against. If you need it, it's a great operation, but if not, then I think we try to get you through, that can get you over these bad days and see if we can get you better with the conservative management before we go ahead and talk about doing this. Last topic we're going to talk about are distal radius fractures. It's the most common fracture that I see. Happens to quite a few people with just sometimes just innocuous falls. It's the #1 common fracture in the upper extremity. It's often a fall on an outstretched hand. The thing that's really key here is that there's a wide variation of fractures, okay? There's simple fractures all the way up to the complex fractures. And the treatment is completely dependent on what the x-rays look like and the pattern of these fractures. But this is your classic fall on an outstretched wrist, and that's where the distal radius is. This is just what the normal wrist joint looks like, and the contour and the anatomy of where that wrist joint articulates with the distal radius. And again, you can't make this diagnosis without doing an x-ray. I often hear people come in, they come in late, they had a fall, they think they can, because they can still move the wrist, they don't think they've had a fracture, right? But you don't know until you get an x-ray here. And then we'll go over some of the parameters and what that looks like as to how we make decisions based on x-ray findings. So I'm not going to get into what all this is, but I'm just giving you some feel of these are the lines and the angles and the relationships that we look at on a normal x-ray versus a fracture. And this is what we actually measure out to determine if that fracture meets the criteria to warrant an operative intervention. And not all of them do, but this is just a representation to these 3 different parameters: inclination, shortening, and tilt. On the right, what you see here is just a relationship of the carpal bones, and focus on that blue line. That blue line, which is called tilt, really comes into play with some of these fractures and determining whether this is going to be operative or non-operative. So I just put this up for representation purposes. I'm not going to go into the specifics of this, but we do look at these things. This is just measured out on a real x-ray, and we get our goniometers out and draw lines and determine what needs to be treated or how to advise the patient appropriately and what doesn't. So this is a pretty typical fracture. And again, I stress that blue line that we showed you before, and see here that tilt is backwards. And so that tilt is going about 20 degrees the wrong direction. Even though that fracture doesn't look, you might not say it looks bad, it looks pretty innocuous. There's a little crack in the bone. However, there's a significant amount of tilt of the joint. And that is something that would require surgical intervention. Not all of them look like that, but that just gives you some indication of what we look like or what we look at. When that tilt is back that far, it can give you what we call a dinner fork deformity to the wrist, to where you actually have a wrist that looks deformed. And so that is obviously something that's not going to heal well, not compatible with function. And so we start talking about indications as to why this needs an operation, but just giving you an overview of to what these parameters are and why we make these decisions. Here, all the lines are off. The tilt is down, the inclination's off, it's shortened. And so this is clearly something that would need an operation. Again, not all of them look like this, but just for illustrative purposes, you can see how this might not heal and how we would have to move forward. So simple fractures, non-displaced, these are terms that we use, non-displaced, well-aligned, extra-articular. We can treat those with a cast or a splint. And we do that for about 4 to 6 weeks and then generally warrant therapy afterwards. The more complex ones, like the one I just showed you, would warrant something surgical. And I'll talk to you about what that looks like. The terms we use for this are displaced, angulated, intra-articular, comminuted, which means more than one piece. Then we need to consider doing something surgical to fix these. But again, that's part of educating the patient, going over the x-rays and having them understand what the risk benefits, alternatives, and why or why not something needs to be fixed or not fixed. So lastly, we'll just illustrate kind of what a splint and a cast look like. This is usually what, for the simple ones, what you're in for 4 to 6 weeks before we start therapy. And then in the unfortunate event, if you have something that is extra-articular, however, angulated, shortened, we sometimes consider fixing these, and we fix them with a small plate like you see here on the right. This is just another kind of illustration of that, and that's how that plate sits in the wrist, bringing that fracture back to its position where it needs to be and giving it the best chance to heal. So the recovery on this, non-surgical, 4 to 6 weeks in a cast with therapy. And then the surgical cases, we begin therapy right away. Splints usually removed pretty early for light hand use, and that's about 8 to 10 weeks, and we expect good return to function with this. So that concludes the topics that we had here, but in summary, I think the considerations, hopefully everybody gleaned at least one thing from this. Most conditions are initially treated conservatively. Treatment options and the response can be dependent on the severity of the problem at the time of the presentation. Early treatment of conditions generally more successful than late. Diagnostics, MRI, EMGs are not always indicated in everybody. Seek early treatment after a trauma, a fall, or an injury because potential fractures are better treated sooner than later in almost every case. So remember that website. I think this is a really good source for people who have issues or want to get a little more information. It's a trusted website written by hand surgeons that won't take you down a pathway of maybe information that's not quite accurate. So I thank everybody for your time and consideration, and we're going to take some questions, and I hope that was helpful for people.
It was a lot of information, that's for sure. It sure seemed helpful to me. So thank you very much, Dr. Vitello. You might have answered this, but I was probably reading through the questions when you did. People are wondering, can you do steroid injections more than once for carpal tunnel syndrome?
So it's a great question. The answer is you can, but we usually reserve that for people who perhaps have other issues where they really can't undergo an operation, aren't safe to. So the answer is yes, you can. It's not generally advised. And the reason for that is the longer that pressure sits on the nerve, the more of a chance you have potentially for that nerve to get damaged. And so you try it once, and sometimes you might get sustained relief. And if you do get sustained relief, then I think it's reasonable to try a second time months later. but it's definitely not something you come in for repeated injections, because at that point, you're not fixing the problem. You're temporarily relieving some of the symptoms, but that pressure's still on the nerve, and pressure over time on that nerve can cause problems. Then when and if, in fact, you do need an operation or potentially need an operation, it's going to take longer for your symptoms to recover. So it can be done in certain cases. Everyone's a little bit different, but not routinely. We don't treat that like we do a trigger finger or a Quervain's tendonitis. And so that's the important takeaway. Carpal tunnel is not tendonitis. It's a totally different issue. And that's why the multiple injections aren't always done.
Gotcha. Thank you. That makes a lot of sense. Someone asks, is there pain or could there be pain in the elbow and the wrist with cubital tunnel syndrome?
Absolutely. Yes. And so the reason that is, one, I showed that one picture of that nerve being kinked, right?
Right.
And that's painful. And when that nerve is being pushed on like that, it can certainly cause pain directly in the elbow. The other thing that I didn't mention here, which is a consideration, is that people can have tendonitis of their elbow that exists about 10 to 15% of the time with cubital tunnel. So
Okay.
absolutely, you can have pain in the elbow with cubital tunnel. Pain in the wrist, you can actually have a compression of the nerve down here on this side of the wrist, and it's still the same nerve, which can cause pain. But oftentimes with pain in the wrist associated with cubital tunnel, it's the pain that is migrating down from the elbow that's causing wrist discomfort, not so much a problem in the wrist, so to speak.
Got it. Thank you. That's very helpful. All right. Someone else asks, could a pinched nerve in someone's neck affect numbness in the fingers? And then they say the neck is not anywhere near the hand.
100%. So yes. And so that is one of the key things to distinguish. You obviously don't want to do a cubital tunnel or a carpal tunnel treatment, or let alone an operation if the symptoms are coming from the neck. So that's part of the physical exam. That's part of the history. Onset of symptoms, you have to ask these questions. But absolutely, all your nerves start in the neck, right? They start in your spine, they come out your neck and down the arms. And so that is one case where an EMG can be helpful, because if you don't know, you absolutely want to be sure you're treating the right location. But yes, 100% issues can start in the neck. And what makes this a little bit more layered or complex is that you can also have issues in the neck and in the elbow or in the wrist, and they can be at both locations. So oftentimes we need to make that distinguished difference, and that's where the nerve test can come in. People often will come in with issues in the neck. They've had an EMG, they've had an MRI of their neck, they know they've got neck issues, but EMG also shows that they've got carpal tunnel or cubital tunnel syndrome. And doing those operations for carpal tunnel or cubital tunnel to give relief of symptoms is much less riskier than a neck operation and can give people relief. And sometimes that's worth entertaining doing, because it is such a shorter recovery and such a much less riskier operation if that is a component of your big picture problem.
Gotcha. Thank you. That makes sense. And another related question, someone asks, how can we tell if my nerve or my severe hand pain and numbness is carpal tunnel or neuropathy? And then they go on to say that their feet are also numb, but the pain down there is not as intense, it's more minimal. So could both conditions be caused by neuropathy, or should they look at other options?
So neuropathy is, just to let kind of get a better understanding, neuropathy is an issue with the nerves themselves, all the nerves. So that's why they can affect the upper extremities, the lower extremities. That's a condition actually affecting the nerve structure diffusely. You can have neuropathy and also have a compression, right? So they can coexist. Yeah. And I can't determine neuropathy in and of itself with a physical exam. And that is another case where an EMG can make that distinguishment, or we can distinguish between the two. What is neuropathy? What's a compression, right? There's peripheral neuropathy, which affects the nerve in general. And there's a compressive neuropathy, which is structural. The structural you can change. if need be, with something surgical like we discussed. The peripheral neuropathy, you can't really reverse. That's treated medically, but that's not something that's going to change with releasing of the pressure.
Thank you. That's great. That's very helpful. Okay. Someone asks, is it possible to manage both de Quervain's and carpal tunnel syndrome simply with splinting at night?
Yes. The short answer is yes. And people with very, very early symptoms of carpal tunnel and de Quervain's, yes. That'd be the first thing I would recommend you do, is wear a splint at night. With the de Quervain's specifically, that's usually a little bit more activity related, where your wrists are under load or they're irritating those tendons with activities. And that's where wearing the splint during the day can certainly be helpful, and plus minus at night. But carpal tunnel, for sure. If you're having numbness at night, that'd be the first thing I would do, is just get a brace, wear it at night, go to bed, try it for a month, and see if you don't get some minor relief of symptoms. And that may be, I've had that. So I've had carpal tunnel, and that's all I did. I wore a brace for about a month at night, and the symptoms went away. Doesn't happen for everybody. I was fortunate. But yes, 100%, that'd be the first line treatment.
Great, thank you. Okay, and does arthritis thumb pain sometimes feel like it's coming from the wrist?
Yes, it does. And people will point, so you have to keep in mind that that thumb joint is only that far from the wrist joint, right? So it's about a centimeter. They're very close to one another. So yes, it can certainly feel like it's coming from the wrist. And you can also have associated arthritis in the wrist right next to the joint of the thumb. And so the two of those can coexist. And you can distinguish that very easily with an x-ray as to where it's coming from and make that diagnosis. Yes, you've got wrist arthritis in association with your thumb arthritis, and that's why you've got pain in both these locations. The treatment changes a little bit, but yeah, you absolutely can have that, and that's a very good point. In addition to having associated tendonitis in the wrist, can be in and around the same location as the thumb. So physical exam can glean that out, pretty quickly, as can an X-ray to make that differential.
Great, thank you, thank you. All right, and this probably will be our last question because we're bumping up against 8 o'clock. Do you believe glucosamine chondroitin can be effective in lessening the severity of pain from thumb and possibly other hand types of arthritis?
I do. So it's not something that I prescribe. And so the party line in the literature out there is, it's never been scientifically proven to improve, but I can tell you, I have countless patients who have taken chondroitin sulfate who have come in and said their pain's better. What is in the literature is that there really are no negative side effects to it. So there's an expense taking it. However, if you're getting relief from taking it, then stick with it, because it's not toxic. It's not going to cause side effects. There's very little to no downside. So although it's not been scientifically proven, I can tell you, just after 20 years, people come in, they've taken it, it helps them. And so who am I to tell them any differently? And so, yeah, I totally support people doing that. I don't generally write a prescription. It's not prescription strength. It's something you can get over the counter, but it certainly is in the treatment realm for people. And I support anybody that wants to do that.
Great, thank you. All right, we do still have 2 minutes, so I will ask you, how about acupuncture for thumb arthritis?
I've had people who have had improvement with that as well. And I certainly support people doing that. And I think there's very little downside. I can tell you, countless people have come back and have tried acupuncture for various things and have gotten relief. And so I am not obviously going to stand in the way of people getting improvement by another means. So yes, there's no question that can be of help. I don't think it's a cure-all for everybody, but add one more layer of things that you can do to avoid an operation, I certainly think it's reasonable.
Super. All right. Dr. Vitello, thank you very much. There are a bunch of questions that we didn't get to. Some of them were way too personal. So if you have personal questions, please make an appointment, see Dr. Vitello, and I'm sure he'll be happy to answer them on a very personal basis. Dr. Vitello, fabulous presentation. Thank you for your time this evening. Thank you everyone who joined us tonight. I hope you learned something and hope to see you next time.
Great. Thanks much.
Take care. Thank you.